Alrighty guys, welcome back to Nursing Made Simple. Let's talk about corticosteroids. We're going to talk about what they are, how they work, why we use them, and then just what do we care about in the nursing field. As usual, we'll try to keep it short and sweet, just what you need for those exams, and hopefully enough information just help you understand the drug class and everything you need to know about it when you're giving it to a patient. So let's jump right in. First thing we're going to start with is what they actually do and how they work. So corticosteroids, we're going to use those for inflammation. They have very potent anti-inflammatory effects, and they also have some immunosuppressant effects. So we have kind of a dual purpose there. Sometimes we use them for one, sometimes we use them for the other. Mostly in the hospital you will see these for inflammation and inflammatory processes. That is typically why you will be giving them. So how do they work? I have the definition up on the board here if you need to freeze the frame, but I'm going to just read it off for you. Corticosteroids bind to glucocorticoid receptors in cells and inhibit gene expression for inflammatory cytokines. So those inflammatory cytokines, real quick, those are a protein that basically signals your body to start the inflammation process. What these do is they bind to these glucocorticoid receptors inside cells and just basically stop them from this gene expression for those inflammatory cytokines. So they just kind of shut the whole process down. They're going to inhibit multiple steps of the inflammatory process. So they don't just do one thing, they just, all along that inflammatory cascade, these things are going to jump in and block it. And then they're going to inhibit phospholipase A2, which is an enzyme for these cytokines. So they're just going to stop it in the beginning of the inflammatory process inside the cells where the gene is expressed. They're going to inhibit this enzyme that's necessary for these cytokines to work. And then if you have high enough concentrations of these corticosteroids in your system, they will inhibit B and T cells, which we know are part of the immune system as well. So if we're using it for inflammatory purposes, we might see one dose, but for immunosuppressant uses, we will see a much higher dose because we need a high concentration of that corticosteroid to actually inhibit the B and T cells. So here's what we're going to use them for. We're going to use them for allergies. Especially big allergic reactions, anaphylactic shock. We're going to use them for asthma. We're going to use them for COPD. Remember, if you've watched my earlier videos on asthma and COPD, those are inflammatory processes in the airway. Bringing down the inflammation will help open up those airways for better breathing. Airway inflammation is a big use for these corticosteroids. Adrenal insufficiency, if your kidneys aren't working right, your adrenal glands, we're going to use them there. Hemolytic anemia. Leukemia, rheumatoid arthritis. These guys are autoimmune disorders. So your body's literally attacking itself. It's setting off the autoimmune system. Corticosteroids are going to help reduce the effects of that, reduce the symptoms. Organ transplant. Corticosteroids are going to be given in high doses for organ transplants because we want to inhibit the immune system from rejecting the organ. So anytime you have a patient with any sort of organ transplant, they're going to be on high dose anti-inflammatory corticosteroids for a long time because we really need the body to not reject the organ. You could see doses of these up to a year long in these patients for organ transplants. And then like I already said, they're just going to have anything where you need anti-inflammatory or immunosuppressing effects. These guys are potent. They will work. So we've talked about how the drug works. We've talked about what we're going to use it for. Now let's talk about some of the adverse reactions or side effects of the drug. So corticosteroids. First off, the higher the dose, the worse the reaction is going to be. This is pretty much true of every med, but especially with corticosteroids, you're going to see worsening effects just exponentially with how high the dose is. So double the dose, your effects are going to get a lot worse, right? So the patients with the really high doses like immunosuppression for organ transplant, they're going to see much worse reactions and adverse effects than your patients who are just on a low dose prednisone to deal with some inflammation from some sort of infection, right? So higher dose, worse reactions. Things that we might actually see, especially with long-term therapy, we're going to see maybe some osteoporosis and fractures. This is because corticosteroids actually inhibit like mineral deposition in the bones. They weaken them actively. It just stops things from calcifying, and the bones don't get that mineralization deposit as easily. So it's going to directly inhibit bone formation and remodeling. So if you already have osteoporosis, you're going to see that on our contraindications list because if you already have it, it's just going to make it worse, right? And if you're prone to it, it might make it pop up. So older women, people on estrogen replacement therapy, you might see the osteoporosis and the fractures. Cushingoid features. Cushing's syndrome is adrenal problem, right? And what we typically see with this is going to be an increase in weight gain, and there's this stereotypical moon face that you see, this really round, puffy face that we see with Cushing's syndrome in the adrenal glands. And this is because the adrenal glands are what produce your body's natural corticosteroids. Anytime you give your body something it produces naturally, then it's going to kind of shut it down. And basically, this happens when the adrenal glands are working in overdrive, right? So if we're pumping you full of corticosteroids, you're having more than you should, you're going to start developing these symptoms of Cushing's syndrome where the adrenal glands are just producing too much corticosteroid. And then we have another problem of when you stop taking the corticosteroids, you might shock your adrenal glands, and suddenly you have the inverse of that, where you have no corticosteroids in your system, and next thing you know, you're in an adrenal crisis. You may also see this buffalo hump, where fat deposits at the base of the neck in the upper back, kind of between the shoulder blades there. It looks like a little buffalo hump. So those are like our three characteristics of these Cushing's syndrome. Diabetes and hyperglycemia. Corticosteroids of any form are going to increase your blood sugar and decrease your susceptibility to the effects of insulin. So the insulin resistance is going to get increased inside your body. So not only are we pumping the sugar up, but now the insulin that your body's producing in the pancreas is not working as well. So you have a double whammy there hitting your blood sugar counts. So if you're already a diabetic, you might need more insulin coverage. If you're not a diabetic, you still might need insulin coverage, because if we're giving you a high dose steroid, your blood sugar is going to go through the roof. Not to mention, the body's natural stress response, one of them is to increase the amount of sugar available to cells inside the body. So if you're in the hospital for some sort of trauma or severe infection, your body's already increased your sugars. Now we're adding more with the corticosteroids, and we're reducing the effects of insulin inside your body. So a lot of patients will complain that, hey, why am I getting insulin in the hospital? I'm not diabetic. Well, now we're giving you steroids and your body's stress response is increasing your sugar, so we have to manage it, because as we know, increased blood sugar is going to make all of our problems a little bit worse. It's going to slow down the healing process for pretty much everything. The body just doesn't work as well when you have suboptimal, elevated blood sugar levels. And then finally, immunosuppression is another big one on our list. We already said that it has potent immunosuppressant effects. It makes sense that that would be an adverse reaction if it gets too bad, because if you're taking these corticosteroids and then you go out into a crowded place and your immune system's all suppressed, it's going to be way easier for you to pick up some sort of infection from wherever you may be. So people who are on immunosuppressant doses of this corticosteroid, say for organ transplant, they are going to need to kind of be careful. They're going to need to have increased hand hygiene and avoid these crowded places. We'll talk about that a little bit more in just a minute when we get to our nursing considerations. Hopping over here, contraindications to corticosteroids. Why might we not want to give them, or what might get in the way of us treating you with corticosteroids? Live vaccines. If you're on corticosteroid therapy, especially long-term high doses, we're not going to give you your flu shot because it's a live vaccine. And we're basically just introducing a live infection designed to help your body's immune system produce some antibodies, right? Like the flu shot. We're introducing that into a now immunocompromised patient. So that's not going to work very well, right? Because we've shunted their immune system with the corticosteroids. We go introducing a live vaccine, and suddenly we give them a huge infection, and there's a big problem because their body's immune system couldn't produce the proper response to then produce antibodies to the vaccine. Hypersensitivity. You're going to see that on every list of every medication as a contraindication. Turns out if you're highly allergic to something, you probably shouldn't be taking it. Go figure. Osteoporosis. Talked about it over here. It's an adverse reaction. If you already have osteoporosis, then you need to avoid the corticosteroids if you can, because it's just going to compound your problem, make it worse. You're going to break a bone, have some problems. And finally, infections. And this is specifically not necessarily just any infection and you're suddenly ruled out of ever having a corticosteroid until it's gone, but more uncontrolled infections are going to cause a problem because like I said, we're going to be shunting your immune system with this immunosuppression, and then you have an infection already. So we're just going to be reducing your body's ability to fight it. Next thing you know, you're septic and the infection is in your entire body and you're going into organ failure. So we're going to try to avoid that. If the infection is well treated, well contained, you're already into your antibiotic therapy, it's not going to be too bad to start some corticosteroids. But if a patient is severely septic and we haven't been able to pinpoint where it's coming from and they're just starting antibiotics, we might be hesitant to start those corticosteroids because we want their body's immune system to fight that infection first. Alrighty, so we're going to wrap up here with our nursing considerations because this is the most important part for a nursing student. You need to know the med, yes, you need to know what it does, how it works, what to look out for, but once we give the med, we need to know what to do as the nurse, right? That's the whole reason we're here. So, hyperglycemia, number one on my list. Anytime you see corticosteroid, think hyperglycemia. A lot of times, it's automatic. Providers, when they order a corticosteroid of some sort, they will order a glucometer check on the patient. And if the sugars become out of control, where we're above like 140, it's usually our cutoff in the hospital. We start getting into the 200 range. They're going to order some insulin to correct that dose, and it's going to be maybe every 6 hours we might check a blood sugar and then possibly give corrective insulin depending on how the patient's body is able to tolerate that corticosteroid. But if you see a new order for this, they may forget to throw in the order for the glucometer check, and we certainly want to check it because, like I said earlier, anytime your blood sugar is elevated and outside of the body's normal, things don't heal as well. Especially if you're on like a trauma floor, those patients' wounds aren't going to heal nearly as quickly. That's why your diabetics have slow wound healing and they have these ulcers that just don't seem to go away, because the high blood sugar and a few other problems with diabetes keep their body from actually healing the wound nearly as fast. So watch out for that. Fluid and electrolytes. We'll see some changes actually. So mostly with our electrolytes here, you may see, especially with the high doses, a decrease in your potassium levels and an increase in your sodium levels. And then these kind of play a part with that hyperglycemia because as we give that corrective insulin, it's also going to shift our potassium. It's temporary, but you will see these shifts. So if you go giving some corrective insulin and then go checking your potassium, it may be slightly skewed, may not be quite right. Chances are it's not going to alter it that much, but you never know. Some people respond differently, especially with a very small individual or an older individual. Their body will respond differently than a young, healthy person. So we may see these fluid shifts. That may mean we need to give them some free water if they have an NG tube, or some sort of isotonic, hypotonic fluid through their IV to decrease their sodium levels. If it starts climbing too high, chances are you won't really see a problem you need to fix, but it is certainly something that could be on the radar in a critically ill patient. And then those potassium levels might just require some potassium replacement, either IV or oral pills. Easy fix, right? Tapering doses. So this is going to come into effect when your patients are discharged, or in patients who maybe go to like an outpatient doctor's office and they get prescribed a steroid and then they take it for X amount of days. Say you're taking it for 5 days. What normally happens is you're going to take this dose for X amount of days, whatever the provider prescribes, and then they're going to cut the dose into a smaller dose, usually in half, and you'll take that for X amount of days, and then you might take the same dose every other day instead of every day. And they're going to taper it down so that you're taking your big dose, and then you're taking a smaller dose, and a smaller dose, and a smaller dose, until the treatment is complete with that corticosteroid. This is what's going to help your patient from going into that adrenal crisis that we talked about, along with that Cushing's syndrome, the opposite of it. If they suddenly stop taking their high-dose corticosteroids, it's going to shock through your adrenal glands, and then suddenly your body has no corticosteroids, and you're going to see this syndrome of adrenal insufficiency popping up, right? Because it's going to take some time for their body to compensate and start producing its own again, since we've been artificially supplementing the body's adrenal glands, and then we cut it off and they're like, hey, where'd all my corticosteroids go? It takes a little while for them to kick in and say, okay, I'm going to start working again. So we want to avoid that because that can have some pretty serious side effects. Risks of infection, since we know that corticosteroids now have potent immunosuppressant effects, especially for those patients, cancer patients and those organ transplant patients on high doses, we're going to be super concerned about this risk of infection. So you should know by now that nurses' number one way to reduce infection in patients, hand hygiene. Wash in and wash out of the room, make sure visitors wash in and wash out. Okay, make sure your patient's washing in every once in a while. Keep a clean patient. Don't let your patient get all dirty in their bed. It's nasty. So, number one way, hand hygiene. Other ways we can do it, if we're concerned about these patients with a super depressed immune system, we may throw them in what's called reverse isolation. So instead of isolating a patient because they have a disease, an infection, we'll isolate them because they don't have an infection and we want to keep it that way. So that means that we're going to gown and glove up as the nurses, and anyone that goes into that room, we're going to wear a mask to keep from breathing on the patient. We're just going to do everything we can to prevent spreading bacteria onto them while we're treating them. That goes for visitors, that goes for doctors. Reverse isolation is actually a thing. We do it for a decent number of patients. We may ban in the hospital live plants. A lot of floors now just straight up aren't allowing patients to have live plants anymore. There's a huge amount of bacteria in the dirt that comes with potted plants. And so when people bring a potted plant into an ICU, we're introducing a huge risk of infection to all the patients on the entire unit. Because what happens, a nurse goes in, they accidentally touch the flower pot or whatever, or they water the plant for the patient, and next thing you know, they've just walked out, forgot to use their hand sanitizer, and walked into their other patient's room, and we just, spread a whole bunch of bacteria all over the place just because someone had some potted plants on their desk. So some hospitals are implementing that now, where they reduce the amount of live plants allowed in there. Fresh fruits and vegetables brought into the hospital. If you're not washing your vegetables and your fruits well, a lot of bacteria get stuck on those, especially the real rindy fruits like a cantaloupe or some sort of melon. Oranges with that little more coarse peel, it's a little harder to wash all the bacteria off of those, and it does not take much when you have a body full of corticosteroids and your immune system is at ground zero. And then lastly, if we're taking concurrent NSAIDs, we have an increased risk of stomach ulcers. Most hospitals, the standard is going to be that if you're in the hospital, you're going to get some sort of proton pump inhibitor to prevent ulcers from forming inside your stomach. Because again, body's natural stress response to injury and illness, part of that is to increase your sugars, and then another part of that is to increase the production of stomach acid, crank it up, right? And then the more acid is in your stomach, the more it's going to be eating away at that lining. You develop an ulcer. Next thing you know, you're bleeding out of your GI system, and we've got to treat that now too. Almost all patients should have some sort of PPI or H2 receptor blocker medication put on their list to prevent these ulcers, especially if you're taking high-dose NSAIDs for a while, and doubly especially if you're taking them in concurrence with the corticosteroids. Something about them works together, huge risk of ulcers, and we want to prevent that because a GI bleed is just going to make everyone's day a little bit worse. So these are our nursing considerations. As always, there are more, but these are the ones that I consider the most important. So hopefully you learned something from the video. If you liked it, like and subscribe. If you have questions on it, hit me up in the comment section. I will respond to the best of my abilities. And if you haven't already, go back and watch my other videos on asthma and COPD, because they do pertain to the use of corticosteroids. Those are our two main uses for these steroids in the hospital. Everyone's got COPD, so we use them all the time for those kind of patients. Thanks for watching, and I hope you tune into the next video.